Welcome, everyone. We will go ahead and get started here. Um, the first on the agenda So, before we start today, I'd like to make a few remarks about the passing of a friend. Today, we mourn the recent passing of House Speaker Mike Bush. Our thoughts and prayers go out first and foremost to his family and his staff. Speaker Bush had an impact on every corner of the state and touched an array of public policy issues, very particularly here at the Healthcare Commission and in healthcare. His service until the last days of his life are a lasting tribute to his public service and his love for Maryland. Regardless of where one stood on issues, everyone agreed that Mike Bush was unselfish, intelligent, and generous. We especially appreciate his longstanding commitment to providing access to affordable health care for all Marylanders and his support for Maryland's unique approach to health care delivery and the all-payer model. Over the years, we count on him to provide special attention to the work of his commission, first protecting small group market reform and public reporting, and more recently in the areas where we play a major role, including CON reform, health information technology, and the evolution of Maryland's longstanding all-payer model. I personally remember Mike clearly from the time when I first worked with him in the late 90s, early 2000s on the establishment of the Trauma Fund, on many things that led to the further development, reform, and improvement of the state's trauma care system, and right up until the end on the recent changes in the Trauma Fund. I spoke to him last about 2 days before he passed. So in his hospital room, and he was lucid, clear, and articulate. And one of the things that I'll remember most about him is that despite the breadth of issues that he faced on a day-to-day basis as speaker, his content expertise with regard to healthcare was substantial. It didn't take long to get him up to speed on the issue when you wanted to talk. And when he agreed with you and agreed to proceed, you were done. That was the end of the discussion. Usually you move forward, and when he didn't, he let you know that too. He'll be dearly missed. Take a moment of silence. Thank you. On a brighter note, on this past Monday, Governor Hogan appointed Mr. Chip Dordan to fill Bob Moffitt's prior position here on the commission. Chip is with us today, sitting in the front row. Stand up first. Hello. Welcome. Mr. Dordan's held positions in healthcare delivery for his entire career. He served as CEO and president of Anne Arundel Medical System from 1994 to 2011, and as president before that from 1988 through 1994. Chip directed the growth of Anne Arundel from a community hospital to, by 2011, a regional healthcare delivery system with over 3,200 employees and an annual budget just north of $500 million. Dordan holds a Master of Arts in Healthcare Administration from GW, a Master of Science from the University of Maryland, and a Bachelor of Science from the University of Delaware. He served with the Army from 1968 to 71, including service in Vietnam from 70 to 71. And he will begin his service next month after he takes the oath of office. Welcome. This is into one. Okay. Included in your packets are copies of the. Yeah, doesn't take much to confuse me. Included in your packets are copies of the minutes from 2 sets of commission meetings, which include the March commission meeting and 1 commission legislative meeting that took place by conference call. Approval of minutes for each meeting will need a separate motion and vote. I'll take the minutes in order, beginning with the March commission meeting regarding pending legislation that took place by teleconference. The teleconference. I have a motion to approve the March 15 minutes. Mr. Peters, and do I have a second? Mr. Hammerstein. Any discussion, comment? All in favor?
Aye.
Any opposed? Okay. So there, on the phone, we have Commissioner Thomas, Commissioner O'Grady, Commissioner Hasty, and Commissioner Tamarchio. Is that correct? Anybody else?
Yep.
Okay. Next, approval of the minutes from the March 15, 2019 public meeting of the commission. Isn't that what we just did? I'm sorry. Now, I entertain a motion to approve the minutes of the March 21, 2019 public meeting of the commission. The 21 meeting. March 21. Yes. Correct. So she was here, and she is listed as having seconded several motions. So likely that she was present at the time. Got it. So with that correction noted, do I have a motion to approve? Second. Any further discussion? All right. All in favor? Aye.
Aye.
Opposed? Hearing none. Updates next. Ben?
So you've received our staff update. I had a couple additional items. First off, I want to thank the commissioners and staff for diligence in attending the legislative meetings over the last 3 months. I think you'll hear later today that we had a pretty successful legislative session, and we couldn't have done it without the active engagement of the commissioners in those 8 o'clock meetings. I recognize that some were already breaking in midday to attend those, and others were changing their schedules to participate. And I want to thank you very much for your engagement throughout. I also want to bring to your attention that we have received the final report for the Office of Legislative Audit. They conduct a review of the commission, the HSCRC, and the Community Health Resources Commission. I believe it's every 3 years. They had one finding. That finding pertained to the administration of the trauma fund, that they felt we should strengthen our procedures and controls over the fund. Specifically, they focused very heavily on the separation of duties. The commission staff gathers the reports from the individual hospitals for on-call payment and evaluates them, and then issues requests to the comptroller to make payments. The auditors felt as though we should be segregating duties more distinctly among the administrative staff. We do have a small staff. We pointed out to them that in this particular instance that there was an individual who had a long-standing medical leave issue, but we will strengthen those procedures so that the duties are fully segregated. No finding of any problem, but in terms of best practices for accounting, we need to make sure they're segregated. The second issue was there was a miscalculation on on-call payments to several hospitals that the auditors identified. There is a defined formula under which the hospitals that the level 2s and level 3 trauma centers receive. And in reviewing those calculations, they found several errors. As we pay the hospitals twice a year, the recoveries have been made from subsequent payments, but we will institute a more rigorous review of those on-call payments in the future. We've communicated our approach to the Office of the Legislative Auditors and also shared that information with the Department of Health, Office of Inspector General, and both are satisfied with the approaches that we're taking. Given the end of the legislative session, our work groups are going to resume in earnest, and just by way of a quick review, the infant mortality work group that was established through legislation in 2018 is now working diligently in developing some recommendations on innovative programs that the state might consider. The next meeting will be on June 4th with the goal of continuing to meet through the summer, developing recommendations both on new programs that might be considered, as well as a recommendation on whether it would be appropriate to establish a permanent commission on infant mortality. At this point, I think the questions, somewhat still being considered. The state has had mixed results with single-purpose commissions in the past, and clearly one major factor is where would the funding for such a commission come from. If it's a commission with no access to either the general revenues or another source, tends not to be too effective. We have 3 work groups on various issues related to health IT. Those are all going forward, and you'll begin to receive, beginning in May, a presentation on the first of those. All of those we are aiming to have final reports before the start of the 2020 session. And lastly, just to be sure everyone is aware, our work with the development of the refinement of the state health plan continues. We will begin a work group on the update of the state health plan for acute psychiatric services beginning on May 3rd. We would like to solicit a commissioner to participate, if possible, in those work group meetings. We anticipate 3 to 4 meetings over the next 3 to 4 months, with then that draft state health plan brought to the commissioners, hopefully by mid-fall. The goal being to have a new state health plan for psychiatric services in place by the end of the year. House Bill 626 does require us to report in the next legislative session on the work on this work group. So we really hope to complete our all of the refinements before the start of the next legislative session. A couple procurements that either have been awarded procurements and interagency agreements. As I indicated last month, we have established an interagency agreement with the School of Public Health at the University of Maryland in College Park to assist us with the infant mortality study. That they will assist us with the work groups and the development of the final report. We also have released a RFP, have not awarded it, for the development of the telehealth readiness tool. You heard a presentation from David's team on work that had been developed with Research Triangle International on a telehealth readiness tool. We've decided that there's enough interest in making that tool available online, and we're seeking a vendor to automate it and make it available to providers here in the state to assess their readiness for adopting telehealth services. Our recompete of our quality measures data center procurement, a fairly large endeavor, very large by the standards of the state, continue, and we hope to have an award by the early part of June on that effort, but no final conclusion at this point. And we will be releasing a procurement, an RFP, to begin the work required under Senate Bill 1010, which requires MHCC and the Office of Healthcare Quality to begin an assessment of services at Chestertown Hospital. That support for that work will be procured through an external contractor, and we expect that work would be completed by the mid part of the fall, with a report to you by December and to the legislature by the 1st of January. That concludes my updates. Happy to take any questions on that.
Technology straight. I had one question, Ben, on the report on MACC submissions. It looks like the number of clean submissions has gone down, while the amount of data under review, I'm sorry, not MACC, for the all payer claims database. They're all MACC. So it looks like the number of clean submissions from payers has gone down, but it's expressed sort of in terms of number of payers. I was wondering if there's any sense of how much that impacts the data, like what's the volume of data that's being impacted? Is it similar percentages?
Thank you for your question. As far as impact of data is concerned, right now, what we are looking at is that payers are spending more time in the data review process. So the reason for that is that we have some new people at our vendor. We have lost some key people that were assigned to the project. So right now, they're spending a lot of time doing the data review process. This is not a payer submission problem, but once this information is being submitted to the MCDB, they spend a lot of time during the data validation checks. So as a result of the time that's spent, they respond to payers. It's taking more time to respond to payers. So that kind of backs up the for payers to respond. So what happens is that they're supposed to respond to payers an average of 3 to 5 days, well, they're taking like 10 days to do so. So right now we are working with SSS to have these people come up to speed, in their data review process. They're not making errors, but it's just that they take a lot of time to actually.
So it sounds like that's the kind of thing that will resolve itself as they get up to speed.
As they get more experience, yes.
Thanks.
All right. Last month, Commissioner Sargent requested an update on plans for displaying more episodes of CARE through the Where the Cost initiative. Mahi Nagatu, Chief of APCD Public Reporting and Data Release, will provide an update on plans for publishing additional episodes of CARE. Mahi.
Thank you, Chairman. Good afternoon, Commissioners. As part of the expansion of the Where the Cost episode of CARE consumer website, staff worked with Alterum, that's an MACC contractor, to get the Prometheus output for Medicare 2015-16 data. Alterum provided the data set which was then validated by staff. 9 episodes were identified as ready, and these were joint replacement, hip and knee, lumbar, spine fusion, stroke, pneumonia, AMI, hip and pelvic fracture, PCI, and CABG. As a note, CABG was customized to meet the definition of CABG according to the cardiac surgery and PCI service COMAR 1024-17. At this point, for a typical data release life cycle, which we have followed in the past, the episode of CARE results is shared with the Where the Cost consumer work group for feedback and comments, which is followed by the hospital vetting process and then testing by consumers before the public release. However, since we're doing this for the Medicare for the first time, we wanted to have further evaluation of the Prometheus output to ensure the accuracy of the results. So for this task, we have identified remedy partners that have experience working with the episode of CARE and Medicare data with their involvement in the PCI implementation, the BPCI, the bundle payment for care improvement implementation. And since it comprises of the original HCI 3 team that developed Prometheus software, we wanted to have remedy look at this. But most importantly, it is because of their experience working with the Prometheus outputs, which is customized for the Where the Cost. So remedy partners will assess the work done by Alterum, so that is, they will get the data set and then perform their evaluation on the final table and also do some spot checking in the underlying data. And once the result is evaluated, we'll proceed with updating the website, the test website, to proceed with the work group meeting and also the consumer testing. Meanwhile, we have also been working on preparing the website to include the Medicare data. This consists of adding new episode pages and also making sure that the web content aligns with the new episodes. So as I mentioned earlier, some of them are acute episodes, which is a little different than before because we focus more on procedural episodes. So we want to align our content to that as well and also be able to add new definitions. So the other branch of where the cost is the communication and outreach. So we have hired the Hatchers Group that will support development and implementation of a comprehensive communication strategy. They have been doing a great work in that aspect. And just to provide you highlights, we have a 6-month social media ad and campaign that was implemented in March. This includes Facebook and Twitter ads and boosts. And we have also seen an increase in the referral from social media content and a total page view increase. In other words, the visitors of the site spend more time looking at the content of the website, which has helped us reduce the bounce rate. The other task we have also done was the development of a new blog post that focused on the CMS rule on price transparency and what it means for the cost. So the plan is to have one blog post per month and promote that. That will also help us keep visitors engaged until we update it with the new data. So in terms of future plan, the near future plan is to successfully complete the Medicare 2015-16 data release, which will be followed by the commercial 16-17 data release. And we will continue on expanding or adding more episodes. And this is by, as I mentioned earlier, not just limiting the episodes to procedure episodes, but then including more acute episodes as well. The other part of the future plan is to increase visitors' engagement. And one of the things that is new that we're planning to do is send out email reminders especially to those who have signed the appeal that we have implemented in the last release and have indicated that they want to be involved. So we have, among those who have signed the appeal, around 75% of those have indicated that they want to be contacted. So we want to keep them engaged and send monthly reminders on that. So that's just a high-level update. So I'll be happy to answer any questions.
Oh, thank you. The person that instigated it. Thank you for putting that together. So when do you think the next 11 episodes are likely to be sort of up on the site and live, through the end of the process?
So in a normal, typical cycle, it takes 4 months. So this is preparation of the data that takes about 6 weeks, and then the data review for the hospitals. That's around 3 weeks. We give them around 3 weeks to get the data. So that's about 4 weeks, and a total of like 5 months is what a typical cycle takes. So in this case, we needed that additional step from the review by Remedy Partners to tell us if the result is accurate. So we have they've provided us a timeline of 2 weeks at least to look at this. So which will be preceded by the hospital, the work group review, and then the consumer testing. So the Medicare data is a little different from the others because we needed to add this additional step. And going forward, for instance, for the commercial data, we would need this additional reviews and intensive validation, for instance, by the work group, because most of we know that the Medicare, the commercial data is stable in terms of running it against the. So we expect at least June or end of June is what we have anticipated for the Medicare data. Yeah.
And we currently have 4 episodes, and this would extend it to 15. How many? This is going to be a hard question to answer.
Yeah.
What's our vision end state? How many episodes would we say this is a complete, full site? This is the project we've done the best of what out there. Obviously, we're not going to eventually put every medical procedure that exists on the site. Do you have an idea of whether we're talking 100 or 50 or 3,000 or something like that?
So Prometheus software doesn't generate that many. The total is 90. So it's also limited by the fact that we want to look at both cost and pack rate. So if we go by just looking at the cost information, we would be able to include more episodes because these reliability score calculations are done on the pack rate, and then we are limiting episodes where we have a lot of volume for both cost and pack. So going back to your question of how many is potentially available, so the Prometheus software generates 30 procedural episodes. So that's the potential in terms of like, okay, we'll just report episodes and then report path when it's available. And then if we go into like chronic episodes, which cannot be attributed to a hospital, we might have to kind of change the website in some way. But then acute episodes and procedural episodes, we can expand on those more than what we have right now. So there are various ways that we can navigate this. But the limit is 90, not 3,000 or so.
So of the 11 that you picked, is there a process that, for, obviously you talked about vetting things with the hospitals, but what about other expert groups? For example, you talked about the category of hip and pelvis fracture. And in the Medicare population, those are two wildly different things, hip and pelvis fracture. They happen to lump them all together in one code, but they're wildly different in terms of cost. How do we sort that out? How do we make sure that we're not reporting them as one line, which is not helpful?
That's a great feedback. So that was one of the things with the CABG episode as well, because the Prometheus software clubs CABG and valve surgery. I mean, CABG with valve and CABG without valve together.
Right.
So we have customized the code to just look at CABG. So then align with the isolated CABG definition. So our thinking was to provide this to the work group and get feedback on in terms of the relevance and the accuracy of, for instance, the hip and pelvic fracture episode. So these are just ready. It's not that we might include. I mean, if they are found to be ready and that there is easier way to parse out pelvic separate from hip, that could be done because we have done the same thing for the hip replacement and revision, hip revision episode. The joint replacement episode also club both the revision and the replacement. So we had to pass out those as well. So anything outside of that is done post episode construction, it's easily manageable. That doesn't require us to go through the rerunning the software. So those are changes that we see.
Great. Other questions for Mike? Yeah.
Just had, I'm just curious on the trauma fund. Then I see that there's like a $3 to $3.5 million surplus projected, which is great, but what happens with that?
So we are expected to have about a 10% cushion in our budget year to year. What happened, how that developed was that up through from 2008 to 2017, we had no additional increase on our funding cap, which was for those 9 years, $12 million. In 2017, sort of unexpected, at the end of the year, at the end of the legislative session, we were able to get the cap raised. So in 2017, although our ending cap was raised to $16 million, we were still operating on the premise that we would be needing to have $12 million would be the maximum. So quickly, we went from not having enough of a surplus to we had a surplus that was above what we would call desired levels. if you don't spend your surplus over a period of time, it becomes potentially a target for reallocation by the Department of Budget Management or by the legislature. So we have strategies to spend down. This year, what has also caused us to not be successful at reducing the budget is we've had a number of retirements, in some instances unexpected, that when we lose staff, that those funds go away. So it's likely that we will close out the fiscal year with probably a budget surplus of about $5 million, and we have to take steps to reduce it. On the supply side, we're also reducing our assessment to providers and payers slightly to bring our collectibles in line with what our funding needs are. But your observation that we don't want to maintain year in, year out a growing budget surplus.
Was your question related to the trauma fund surplus?
Oh, okay. I thought I had a sidebar conversation here. Yeah. So the trauma fund surplus is really somewhat the same issue, but there the surplus is somewhat a function of what are the statutory authorities under which we can release funds. So beginning in 2002, we had the authority to pay hospitals for their on-call trauma expense, and physicians serving at those hospitals, uncompensated and Medicaid underpayments. Over the next decade, we changed the funding streams that were permitted, which helped. But beginning in 2014, we had the ACA kick in, and Medicaid underpayment virtually disappeared. And uncompensated care payments disappeared because everyone went into Medicaid. So since 2014, we've been monitoring this growing fund balance. Last year, a portion of it was removed. This year, we determined there was an additional funding need up to this year. The shock trauma, the primary trauma center in the state had not been eligible for on-call and standby. As a result of legislation, they will become eligible. The commission is required to develop a methodology. We think that will reduce the budget surplus we have on the trauma fund. But I think we also recognize that long term, we need to think about are the flows that were established back in 2003 when the fund was established consistent with the needs of the trauma system today. And I think there's recognition of all players that while the need for standby and on-call funding at shock trauma is real, there may be other needs that have materialized, and conversely, there may need to be some rethinking of the on-call payments that are made elsewhere in the system. Not that I'm saying they should be reduced, but some thinking about that going forward.
Other questions for Ben? Staff, hearing none. We move on to agenda item number 3. All right. Action item, Certificate of Need, Atlantic General Hospital Corporation, establishment of an ambulatory surgery facility. Atlantic General Hospital is seeking a CON to establish an ambulatory surgery facility in Ocean Pines to be comprised of 2 operating rooms, and upon opening the center, the hospital will close one of its 4 operating rooms. Bill Chan, Program Manager in the Center for Health Facilities and Planning, will present the staff recommendation. Bill?
Good afternoon, Chairman Pollack and Commissioners. The applicant, Atlantic General Hospital Corporation, operates Atlantic General Hospital, a 45-bed general hospital in the city of Berlin, located on the lower eastern shore in Worcester County. Atlantic General is the only general hospital licensed to operate in this jurisdiction, serving the seasonal beach crowds that visit Ocean City during the summer. Atlantic General seeks to establish an ambulatory surgical facility in a medical office building currently under construction in the community of Ocean Pines, which is approximately 3.5 miles or a 7-minute drive from the hospital. Upon completion, the ASF will have 2 operating rooms and 3 procedure rooms. The remainder of the medical office building will consist of a number of primary care and specialty physician practices, include an urgent care center, an outpatient medical laboratory, an imaging center, outpatient rehab, a pharmacy, an infusion center, and a dialysis center. The ambulatory surgical facility will go by the name of Atlantic General Surgical Center. Atlantic General would take one of the existing operating rooms at the hospital out of service, reducing the number of mixed-use general purpose operating rooms at the hospital from 4 to 3. The 3 procedure rooms at the new ASF will replace rooms that are currently in leased space within a medical office building adjacent to the hospital. In addressing the need, staff finds the applicant's projections regarding demand for surgical services and needed operating room capacity is optimistic, based on the recent trends of declining demand for inpatient surgery observed at the hospital, and the applicant's much higher rate of growth in demand for outpatient surgery than suggested by these recent trends. Between 2015 through 2018, the applicant observed a decline in the number of inpatient surgical procedures performed at Atlantic General due to the loss of a general and orthopedic surgeon from the medical staff, causing a loss of inpatient surgery market share for the hospital in Worcester County. Offsetting this trend in inpatient surgery, Atlantic General provides generous projections on the number of outpatient surgical cases performed by not only the surgeons currently on staff at the hospital, who will move a substantial number of outpatient surgical cases from the hospital to the ASF, but also as a result of recruitment of 5 new surgeons who will add their outpatient surgical volume by fiscal years 2020 and 2021 to the ambulatory surgical facility. Atlantic General projects that by fiscal year 2023, the 5 operating rooms at the hospital and ASF would be highly utilized, with each exceeding optimal capacity as defined by the General Surgical Services chapter of the State Health Plan. Atlantic General's modeling projects the growth of outpatient surgical case volumes in excess of 10% between 2018 and 2023, which is highly optimistic. Using a more considered scenario to forecast utilization, staff used a 3% growth rate for the period 2018 to 2023 for the average annual outpatient case volume at both Atlantic General and the ASF, and maintains the hospital's forecasted projections for inpatient case volume. Using this modest growth rate, projected surgical case volume would still provide sufficient utilization to support the need for the 3 operating rooms at the hospital and the 2 operating rooms at the ASF. With the use of a 3% growth rate in outpatient surgical case volume, Atlantic General would still meet the minimal capacity use standards for the proposed ASF. Regarding construction, the applicant will work with Cena Company, LLC, a medical real estate development company. The estimated cost for fitting out the ASF within the medical office building is approximately $8 million, but the applicant having sufficient funds on hand to provide about $2.9 million in cash to purchase the furniture and equipment for the facility. The companies who will build and own the medical office building will fund the remaining estimated balance of $5.1 for the fit-out of the ambulatory surgical facility. CENA will finance the construction costs for this project with a combination of debt and equity. With the completion of construction, the relationship between Atlantic General Hospital and CENA will simply be that of landlord and tenant, with the applicant entering into a 15-year leasing arrangement, with an annual payment of around $691,000, with an annual 3% increase to the minimum rent. As previously mentioned, Atlantic General is the only facility that currently provides surgical services on an outpatient basis in Worcester County. So there is a facility with 1 procedure and no operating room that performs pain management procedures only. The primary impact of the project will be on Atlantic General Hospital, where the hospital projects moving approximately 44% of its total operating room time to the ASF by fiscal year 2023. The applicant wants this shift to occur in order to move outpatient surgical volume from a rate-regulated hospital setting to a low-cost setting such as the proposed freestanding ASF. In summary,
The project complies with applicable standards in COMAR 10/24/11, General Surgical Services Chapter. Is needed. Is a cost-effective approach to meeting the project objective. Is viable. Will provide a benefit to residents in the service area seeking ambulatory surgical services and not have an adverse impact on costs and charges for these surgical services. Staff recommends that the Commission approve Atlantic General Hospital Corporation's application for a CON authorizing the establishment of an ambulatory surgical facility with 2 operating rooms and 3 procedure rooms at a medical office building located in Ocean Pines, Worcester County, at an estimated cost of $2,850,444. That's the end of my presentation. And before I guess if you go to questions, I'd like to introduce representatives from Atlantic General Hospital. To my left is Ms. Colleen Waring, the Vice President of Patient Care Services and Chief Nursing Officer, Mr. Ken Gillis, Director of Surgical Services, and then Richard Caldwell, their consultant. Thank you.
Welcome. And just to be clear, Bill, this, if I understand the new law correctly, as of October, this would just be an exemption, correct?
It would be, yes, correct.
Okay. So if we don't like it today, they can just get exempt in October. The commissioners, any questions?
Yeah, I'm sorry, just a couple of quick questions. Again, I'm assuming it's all deregulated services, non-regulated surgical services. Is that correct?
Non-rate regulated.
Okay, non-rate regulated. Is there any adjustment to the shift in volume from inpatient out of their GBR in that hospital?
That's an HSCRC question.
Okay, I'm just curious. Is there any? There's no discussion about that. Or is there any change?
Well, this action gets reported to the HSCRC, so they're aware of this occurring, and then they monitor changes in volume from there.
And then the only other question was, there's reference to a medical building on campus. Is that a hospital-owned building, or is that somebody else?
As I understand it, it's a leased building by Atlantic General Hospital Corporation.
Okay, not owned by the
They have a number of outpatient services that they lease or have ownership interest in,
Right.
with or without the position.
Okay, they don't own the building. Okay, good. Thank you.
Are there other questions? Hearing none, do I have a motion? Motion, second? Seconded for 2 meetings in a row. All in favor?
Aye.
Aye.
Anybody opposed? Congratulations, you have your CON.
Thank you.
Thank you. Action item number 4 is a pair of requests for exemption from CON from Shore Health System. And then in action number 5A is a certificate of ongoing performance for cardiac surgery services for the University of Maryland St. Joseph Medical Center. Since all 3 of the action items involve the University of Maryland Medical System, I will recuse myself from the discussion, and Commissioner Sargent will run the proceedings.
Thank you. You're in trouble now. So, agenda item 4 is a pair of requests for exemption from certificate of need review from Shore Health System. Shore Health System seeks 2 exemptions from CON to reorganize and modernize its facilities in Dorchester and Talbot counties. We will consider each of these requests separately. I'll note Shore Health System has also submitted a CON application to replace the University of Maryland Shore Medical Center at Easton with a modern facility in a more accessible location. The Commissioner will consider that application in the future. For the first item, action item 4A, the conversion of the University of Maryland Shore Medical Center at Dorchester to a freestanding medical facility, is an exemption from certificate of need review. Seeks to convert the general hospital in Dorchester County to a freestanding medical facility to be constructed about a mile from the existing hospital. Kevin McDonald, the Chief of Certificate of Need, will present the staff recommendation on this request.
Thank you, Commissioner Sargent, and good afternoon, Commissioners. So the applicants are 2 general hospitals operated by Shore Health System.
University of Maryland Shore Medical Center at Dorchester, and the University of Maryland Shore Medical Center at Easton. Shore Medical Center at Dorchester currently operates 24 med-surg beds and 18 psych beds in Cambridge, Maryland, in a facility built incrementally between 1906 and 1960, with a number of renovations during that period and since then. It had just over 2,000 admissions in 2018, and over the last 5 years has averaged around 20,000 emergency department visits. Shore Medical Center at Easton is licensed for 104 beds and about 15 miles away in Easton. For some background and context, as Commissioner Sargent mentioned, this is the first step in Shore's plan to reorganize and modernize its facilities in Dorchester and Talbot counties. Shore has also submitted a certificate of need application to replace Shore at Easton with a more modern facility in a more accessible location. And we will deal with that in the future. And the next item on the agenda, which is another request for exemption from CON, would relocate some of the medical surgical beds and psychiatric beds from Cambridge to Easton, where they would essentially serve as an interim step until the proposed replacement for the Easton facility is completed. Considering the regulatory framework for this action, a freestanding medical facility is an outpatient healthcare facility that is essentially a freestanding emergency room, but can also include observation beds and other rate-regulated services. Legislation passed in 2006 created a pathway for a general hospital that is part of a multi-hospital system to transition from an inpatient facility to a freestanding medical facility through an exemption from certificate of need review. The process, there is still a review process, but that requires approval by the commission. But unlike the CON review process, it does not allow for intervention by interested parties or judicial appeal by interested parties. And this review is governed by the State Health Plan chapter on freestanding medical facilities. And under that plan, an exemption can be issued if the commission finds that the proposed action is consistent with the State Health Plan, will result in more efficient and effective delivery of healthcare services, will maintain adequate and appropriate delivery of emergency care within the statewide emergency medical services system as determined by the State Emergency Medical Services Board, and is in the public interest. The proposed FMF would occupy the first floor of a 2-story building and would have 22 emergency department treatment spaces, 6 observation beds, and several other rate-regulated services, including cardiac rehabilitation, infusion services, intensive behavioral health and substance abuse outpatient treatment. And I will note that the initial staff report that was posted incorrectly identified those other services as unregulated, and they are rate-regulated services. The second floor of the facility would house a medical office building. So the staff review again entails those 4 items that I mentioned earlier: consistency with the State Health Plan, public interest, maintaining adequate emergency coverage, and more efficient and effective healthcare services. And I'll talk about each one of them in turn, starting with the most clear cut, maintaining adequate and appropriate delivery of emergency services. The State EMS Board, the Maryland Institute for Emergency Medical Services System, needs to examine 11 factors in making their determination whether this requirement is met. They found positively on that in October of 2018. In looking at consistency with the State Health Plan as measured against the review standards in the FMF chapter, staff had no trouble concluding that the proposal was consistent with most of the state health plan chapters. However, as discussed at some length in the staff report, an initial examination of the proposed number of ED spaces and observation beds seemed out of compliance with the standards governing the number of spaces, as well as the overall size of the facility. Our standards are based on the American College of Emergency Physicians Guide, which recommends the number of rooms and spaces and corresponding physical space in an emergency department based on the annual visit volume of those facilities and the characteristics of the facility and the population that it serves. And it grades down on a low range to high range scale, with a high range ED essentially being a more complex facility that sees a more complex population, a more medically complex population. Our standards are based on the American College of Emergency Physicians Guide, and the applicable standards require that the number of treatment spaces and the size of the facility proposed by the applicant be consistent with the applicable guidance in the latest ACEP guide for a low-range facility, unless, based on the particular characteristics of the population to be served, the applicant demonstrates the need for a greater number of treatment spaces or additional building gross square footage. SHORE's initial proposal was for 23 treatment spaces, well over the 14 to 16 that the ACEP guidance would suggest. Their projections showed an average census of 9.6 rooms in use, with a peak of an average of 14 during peak periods. They based their need estimate for rooms on a stated need to plan the capacity for the peak hourly census rather than the average daily census, maintaining that the ACEP guideline doesn't account for that. In fact, it does, and ultimately they modified the proposal to reduce the ED spaces by 1. As stated in the staff report, we were somewhat skeptical about the number and assumptions and judgments built into SHORE's analysis and conclusion, and believe that the number of ED treatment spaces and the square footage in the proposal may be somewhat more than needed under the state health plan, as we saw no reason to calculate the number of spaces needed in any other than the low-range parameters of the ACEP guide, and that planning based on peak incorrectly assumes that ACEP does not build that into their formula, and in fact, they do. However, the staff was ultimately persuaded by a number of mitigating factors which are laid out in the report. Probably the most persuasive arguments are that, unlike inpatient bed capacity, there is no concern that potential excess ED capacity would produce overutilization of services based on the payment system in Maryland. There's not really the same supply creates its own demand dynamic at play there. Also, alternatives are few in the service area, of the rural service area, with only one alternative within 15 miles of Cambridge. Also, the capital cost of adding the ED treatment spaces in the initial build-out is minimal, especially compared to the cost of retrofitting them or expanding the ED spaces at other hospitals in the region. Additional factors include that population health initiatives that are now taking place in the ED are lengthening visit duration. Also, the fact that 2 of the treatment spaces are dedicated to a self-contained behavioral health suite, and 5% of the ED visits with a peak average length of stay of about 12.6 hours. SHORE is projecting a daily census of about 1.5 patients with behavioral health diagnosis would take 2 treatment spaces out of circulation for non-behavioral health patients, reducing the effective capacity of the ED. And finally, as we found in the Laurel, the first of these kinds of reviews the commission looked at, Laurel, we currently lack empirical evidence with situations where long-time hospitals are converting to freestanding medical facilities. As for the observation beds, I should probably start by pointing out that our state health plan standard, which essentially grafts the ACEP prescription for the use of observation space in a hospital-based emergency room onto an FMF, may not be a good match. A more appropriate analogy likely exists with the observation experience of a general acute care hospital. Similar to their planning for the ED spaces, Shore originally built their proposal for 10 observation beds, again, based on peak use. After questions from and discussions with the staff, they modified the request to 6, based on an average daily census of less than 4. And with that change, staff found that the proposed number of observation beds appeared to be justified based on historical and projected use. Finally, looking at the category of more efficient and effective delivery of health services, the existing hospital in Cambridge is old and requires significant investment. It is seeing declining utilization. It's oversized for its volumes and expensive to maintain. Shore projects that replacing the Dorchester facility with an FMF and moving services to Easton combined will save $8 million in staffing costs and another $1.2 million in supplies and utilities on an annual basis. And staff strongly believes that it does meet that criteria. Finally, the public interest, based on all of the factors we've discussed, staff recommends that the commission finds this exemption request to be in the public interest, and furthermore recommends approval of the exemption request.
Thank you.
And I should say that here today is quite a number of people on the team that built this proposal, and I'll introduce Mallory Reagan-Bogan, one of the attorneys representing them, and she will identify the rest of the team, introduce the rest of the team.
Good afternoon. So we do have a number of people here today in support of the SHORE project, so I'd like to go ahead and introduce them. I'd like to start with the University of Maryland SHORE Regional Health Team. First, we have Ken Kazell, the President and CEO. Joanne Hahey, the Senior Vice President and CFO. Patty Willis, Senior Vice President, Strategy and Communications. Bob Frank, Senior Vice President of Operations. Dr. Bill Huffner, Chief Medical Officer and Senior Vice President of Medical Affairs. We also have a few members of the University of Maryland Medical System. First is Donna Jacobs, Senior Vice President, Government, Regulatory Affairs and Community Health. Mike Wood, Senior Director, Rate Setting and Reimbursement and Revenue Advisory Services. And Daryl Mealy, Vice President, Construction and Facilities Planning. And then we also have a couple of consultants from KPMG. KPMG is Craig Wheelis, Director of Healthcare Business Planning Services. Andy Solberg from ALS Healthcare Consulting Services. And from Gallagher, Gillius & Jones, Tom Dame, and myself.
Thank you very much. And thank you for coming in, everyone, especially those of you who came all the way from the Eastern Shore. I know it can be quite a trip. Does anyone have any questions? Anyone on the phone have any questions? Well, with that said, do I have a motion to approve the conversion of the University of Maryland Shore Medical Center at Dorchester to a freestanding medical facility?
Motion. Commissioner Thomas motions.
Would you like the second? Okay. All in favor, say aye.
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 Any opposed? Great. thank you again. You have your conversion.
Thank you.
So we have a Part B. See, Kevin is saying. So Part B, the consolidation of the University of Maryland Shore Medical Center at Easton and University of Maryland Shore Medical Center at Dorchester. The second request is a corollary of the other. It is a request for exemption from Certificate of Need Review to relocate and consolidate some of the inpatient services from Shore's Dorchester facility to the University of Maryland Shore Medical Center at Easton in order to ensure adequate access to inpatient services in the region, especially access to inpatient psychiatric services. Kevin McDonald will present the staff recommendation on this item as well.
Thank you. As we just discussed, this consolidation is really part and parcel of the overall plan for the modernization of the health system on the Eastern Shore. This particular project would move 17 medical surgical critical care beds and 12 of 18 adult psychiatric beds to Easton. Easton has the physical capacity to add these beds and would renovate space on 2 floors to accommodate the relocated beds. And the rationale for the project is to maintain access as the facility in Cambridge is closed, to maintain access to acute care services, particularly to the psychiatric services, which is not currently offered in Easton. Easton has the physical capacity to add these beds, would renovate space on 2 floors. Project would involve renovation of a little over 10,000 square feet on the 3rd and 5th floors, and is estimated to cost $5,379,052. The source of funds would be cash. In order to complete the project, Shore or Easton would relocate and reduce the number of pediatric beds. They'd be relocated from they would be relocated to be adjacent to the existing labor and delivery unit and reduced from 8 to 3. And there's currently an average daily census of less than 1, so that capacity reduction does not look like an issue. To create the space for these beds, Easton would reduce the size of its rehabilitation unit, which is currently located adjacent to labor and delivery. They would reduce it from 20 to 15. Again, the average daily census the last few years has been about 9, and thus that capacity reduction does not look like it would be a problem. This would clear space on the 3rd floor to become available for the proposed 12-bed behavioral health unit that would be moving from Dorchester. Again, the regulatory framework here is that CON regulations permit exemption from CON review for several actions proposed by a merged asset system, including the merger or consolidation of 2 or more hospitals or other healthcare facilities. If the Commission finds that the proposal is not inconsistent with the state health plan, will result in more efficient and effective delivery of healthcare services, and is in the public interest. Commission staff reviewed the request for exemption vis-a-vis the applicable state health plan chapters, COMAR 102410 governing acute care hospital services, and 102407 that addresses psychiatric services, and concluded that this proposal is not inconsistent with the state health plan. A detailed analysis of these provisions can be found in the appendices to the staff report. Looking at the proposal in light of the requirement that it be more efficient and effective in the delivery of healthcare services, SHORE estimates that consolidating the facilities and converting the Dorchester facility to an FMF will result in a reduction of 113 FTEs and save $9.1 million annually in salaries and other operating expenses. There are a number of examples of how the savings will be realized in the staff report. Note that this is an interim step and hopefully only in place for a few years. And staff would also like to note that during the course of the review, changes were made that reduced the estimated cost by more than $3 million. Looking at the project against the public interest, SHORE maintains that this consolidation is in the public interest as a necessary corollary to the conversion of the facility in Dorchester to an FMF, because the proposed consolidation is needed in order to continue to provide adequate access to the services and particularly acute psychiatric hospital services for residents of the service area. Staff agrees with this analysis and recommends that the commission find that the consolidation of inpatient care at Shore Medical Center in Easton, proposed as a corollary of the conversion of the Dorchester facility to an FMF, is in the public interest. Again, there are a number of representatives present. Mallory, I'm not certain if there's anybody different on that list or that be added to that list.
No, same list.
Okay. If anyone has any questions?
Yeah, just a couple of questions. I think this is a good plan. Just timing, so I can kind of understand that. Is this going to happen like in the next 12 months, in the next few weeks? What's the timing on this? And then with the new facility coming down the pike, the amount of money to be spent to renovate that facility, what happens to the old facility and all of those psychiatric beds? Everything be moved over to the new facility at some point in time, or how's that working?
Well, so the plan for the FMF and the merger of beds, the timing is that it will be simultaneous. So the plan is that the FMF will open in summer of 2021 if all goes according to plan and construction proceeds on time. And the renovations will be taking place simultaneously at Easton. Right. And so the day the FMF opens, that inpatient care would essentially, I'm sure there'd be some intermediary transitional steps, but essentially it'll be simultaneous.
So will all inpatient care stop at that time?
Right. So yes, as a freestanding medical facility, you can't provide any inpatient care. And so the day the new facility opens a mile down the road from the hospital, all inpatient care will no longer be provided. Okay. And then, you mean in terms of the facility, what will happen to Dorchester Hospital?
Right.
And so it's actually, SHORE has been working with the city of Cambridge as well as Dorchester County. And actually, I think Ken may be in the best position to talk a little bit about their plans, but there's basically a big community redevelopment, economic development plan in the works with respect to the current hospital site.
Thank you. I'm Ken Kozel, the CEO for SHORE, and this is a perfect example of community partnerships where the county of Dorchester County and the city of Cambridge are trying to revitalize that area. The hospital currently sits on what is the gateway into that community over the Mulcus Bridge right into Cambridge. And as part of the redevelopment efforts with the relocation of hospital services, we would intend to sell our land to the city and county for their redevelopment purposes. So it creates that win-win.
And then again, what was the timing on the brand new facility?
So the timing on the new facility in Easton would be to open our doors in the summer of 2024.
Okay. And all services would move to that facility?
Services from the Easton facility would all relocate to the new hospital.
Okay. And then any idea what's going to happen to that facility?
We would start a community effort to determine best use of that facility as soon as we get the CON approved by the commission. Okay. We can start that tomorrow if you like. We can take care of that today.
Sure.
You can take a couple days off for it.
That's right. Thank you very much.
Thank you.
Any other questions? Yeah. Does anyone on the line have a question? All right. So do I have a motion to approve the consolidation of University of Maryland Shore Medical Center at Easton and University of Maryland Shore Medical Center at Dorchester? Yes, I knew you wanted to. Okay, great. All in favor? Any opposed? Okay, motion passes.
Thank you very much. And if we could take just one moment, Ken had a couple of words he wanted to share.
I'd just like to take a second to thank the citizens of Dorchester County for their enthusiastic support of our vision, particularly the medical staff, our city and county governmental officials, and the health officer of that county. We could not be here today without their incredible support. Also, I'd like to thank the commission staff, and particularly Kevin, who's put a lot of time and energy and effort into understanding our vision, working towards creating the right plan that meets the plans of the state health plan. So thank you very much to the commission staff for your support. And then finally, I'd like to thank the commissioners for approving what is the first in a series of our plans that will strengthen and sustain healthcare services on Maryland's midshore. Thank you very much.
Thank you. So on to agenda item number 5. I'm going to have to come up with our own motion in our own second. Agenda item number 5 is a certificate of ongoing performance for cardiac surgery services. The action involves 3 facilities: University of Maryland St. Joseph Medical Center, the MedStar Union Memorial Hospital, and the Johns Hopkins Hospital. Eileen Fleck, Chief for Acute Care Policy and Planning, will present the staff report for 3 certificate of ongoing performance reviews for cardiac surgery programs. The Certificate of Ongoing Performance application process is a new process that is used to evaluate the performance of an established cardiac surgery or PCI program and determine whether a hospital should be allowed to continue to provide those services for a period specified by the Commission. Today will be the second time the Commission considers granting certificate of ongoing performance to any cardiac surgery program. And as I mentioned, staff will present the report and recommendations for each of the 3 programs: University of Maryland St. Joseph Medical Center, MedStar Union Memorial Hospital, and the Johns Hopkins Hospital. We'll consider each program in a separate action. After Eileen presents the staff report, commissioners may ask questions on that application. Please proceed. I think the first one up is University of Maryland St. Joseph Medical Center.
Thank you. Good afternoon, Commissioners. So the University of Maryland St. Joseph Medical Center established its cardiac surgery program in 1981, and it's located in the Baltimore Upper Shore Health Planning Region, which includes 4 other cardiac surgery programs. It is meeting all of the requirements for a certificate of ongoing performance, which I'll review now. First, each cardiac surgery program is required to participate in uniform data collection and reporting. This requirement is partially met through participation in the Society of Thoracic Surgeons Adult Cardiac Surgery Data Registry. The registry is one that's widely adopted nationally, and the purpose of participation in the registry is for hospitals to receive feedback on how their performance compares to peers. The data is audited periodically by the STS to validate the accuracy of the information provided by hospitals. Hospitals submit information to STS quarterly, and a copy of that data is submitted to MHCC as well. Hospitals are also required to submit select information from their STS performance reports twice a year. The hospital has complied with submission of all of this information. The next 2 certificate of ongoing performance standards pertain to quality assurance activities. The CEO for a hospital is required to certify that a hospital complies with conducting and completing quality assurance activities specified in the chapters, and the hospital is required to demonstrate that it's taken appropriate action in response to concerns identified. Staff has concluded that the University of Maryland St. Joseph Medical Center has provided sufficient information to document its quality assurance activities and the actions it's taken in response to any concerns identified. With respect to the performance outcomes, a hospital is required to maintain an STS composite score for CABG cases that is 2 stars or higher. In the STS composite star rating system, a program may be awarded 1 star, 2 stars, or 3 stars. 3 stars is the highest rating and indicates that the program has performed better than the national average for participants in the STS registry at a statistically significant level. A rating of 1 star indicates that the program has performed worse than the national average at a statistically significant level. The vast majority of programs receive a 2-star rating. The percentage of programs that receive 1, 2, or 3 stars is not fixed. It is based on how well the program performs. For calendar year 2017, only about 6% of the programs received a 3-star STS rating, 3-star rating for the STS composite score, and less than 5% received a 1-star rating. The composite score for isolated CABG has 4 components that are given different weights in determining the composite score.
One component is operative mortality, which is the percentage of patients who do not die during hospitalization for CABG surgery or within 30 days of surgery at discharge. This component is weighted approximately 80%. The second component is the absence of major morbidity, which is defined to include reoperation, stroke, kidney failure, infection of the chest wound, or prolonged breathing support by a machine. The third component that is use of at least one internal mammary artery for the bypass graft. And the fourth component is receipt of 4 specific perioperative medications that are believed to improve patient outcomes. As shown in Table 1 of the report for St. Joseph's Medical Center, the hospital achieved 2 stars or higher for all 6 of the reporting periods shown. The hospital received 3 stars in 2 of the 6 reporting periods. As noted in the staff report, isolated CABG is one of many different types of cardiac surgeries that may be performed. And the hospital performed, the hospital's cardiac surgery volume was primarily CABG. It ranged from 64 to 71% for the reporting period shown. The second performance standard addressed by St. Joseph's Medical Center pertains to the risk-adjusted all-cause operative mortality rate. The specific standard in place for the time period covered by the hospital's Certificate of Ongoing Performance application is not applicable because staff was not able to obtain a valid statewide average for the all-cause risk-adjusted mortality rate. However, staff has provided information in Table 2 of the report on how the hospital performed relative to the revised standard that was adopted in January of this year. So the revised standard uses a national average rather than the statewide average. In order to demonstrate compliance with the new standard, a hospital's all-cause risk-adjusted operative mortality rate for isolated CABG cases must be similar to or better than the national average. Whether a hospital's performance is similar to the national average is indicated by the 95% confidence interval. When the hospital's confidence interval includes the national average, then its performance is considered similar to the national average, which is the case for the University of Maryland St. Joseph Medical Center in 4 of the 6 reporting periods. In the other 2 reporting periods, the hospital performed better than the national average by achieving a lower risk-adjusted operative mortality rate at a statistically significant level. For each of the 6 reporting periods shown in Table 2, the hospital would have met the current standard if it had been applicable. With respect to volume, a cardiac surgery program is expected to maintain an annual volume of 200 cases or more. The hospital has met this standard based on staff's review of the HSCRC discharge data. The University of Maryland St. Joseph Medical Center performed over 400 cases in calendar year 2015 and approximately 500 cases in calendar years 2016 and 2017. Staff concludes that the hospital meets all of the requirements for a certificate of ongoing performance, and we recommend that the Commission issue a certificate of ongoing performance for a 4-year period that permits the University of Maryland St. Joseph Medical Center to continue providing cardiac surgery services. required to certify that the hospital complies with conducting and completing quality assurance activities as specified in the chapter, and that the hospital is required to demonstrate that it's taken appropriate action in response to concerns identified through its quality assurance processes. The hospital has provided a letter from its CEO attesting to this, as well as meeting minutes and attendance lists from 2 meetings of its cardiovascular intensive care meetings, and materials from several other meetings that address its performance on cardiac surgery cases for various performance metrics. Staff has concluded that the hospital provided sufficient information to document its quality assurance activities and the actions taken in response to any concerns identified. The hospital has maintained an STS composite score rating of 2 stars for isolated CABG cases in each of 6 reporting periods, as shown in Table 1 of the staff report. This performance meets the standard in MHC's regulations. The percentage of total volume of cardiac surgery cases covered by this performance measure ranged from 41% to 50%, which is somewhat lower than most Maryland hospitals. But as an academic medical center, Johns Hopkins Hospital provides a much broader range of cardiac surgeries. With respect to risk-adjusted all-cause mortality rates, the specific standard in place for the time period covered by this review is not applicable, as I've explained already. However, staff has provided information in Table 2 of the report that shows how the hospital performed on the revised standard that became effective in January of this year. The revised standard uses the national average rather than the statewide average. For each of the 6 reporting periods shown in Table 2, the hospital's all-cause risk-adjusted operative mortality rate was similar to the national benchmark. The hospital would meet the current standard if it was applicable. The standard for volume is the target volume of 200 cases annually, and the hospital meets the standard based on our analysis of the HSCRC discharge abstract data. The hospital performed over 1,000 cardiac surgery cases in 2015, almost 1,000 cases in calendar 2016, and in calendar 2017, the hospital performed about 800 cardiac surgery cases. Because Johns Hopkins Hospital meets all the requirements for a certificate of ongoing performance, we recommend that the Commission issue a certificate of ongoing performance for a 4-year period that permits the hospital to continue providing cardiac surgery services. That concludes my presentation. There are 3 representatives here from Johns Hopkins Hospital: Diana Alejo, Director of Information Technology; Daniel McFarland, Acting Division Administrator for Cardiac Surgery; and John Hunt, Chief Administrative Officer for Surgery. Thank you.
Thank you, Eileen. Before we go on, can I confirm that there are still people on the line? We've had a couple of technical difficulties. Commissioner Tamarchio, are you still there? Thomas?
I'm still here.
Commissioner
Stephen Thomas.
Yeah. Commissioner Hathey, Commissioner Tamarchio seem to be gone. Commissioner O'Grady. Congratulations, Commissioner Thomas. You're the only one who's managed to hold the electronic connection. Do I have any questions about the Johns Hopkins performance report from anybody on the commission?
Volume decline. Any reason for that? Volume decline, I just noticed that.
Can you step up to the microphone, Sam?
It's simply a turnover of surgeons. Some of our high-volume surgeons have left, and we're actively recruiting for 3 additional adult cardiac surgeons. So we do expect the volumes to return to that level.
Do you know of any information? Any other questions? Hearing none, do I have a motion to approve a certificate of ongoing performance of the cardiac surgery program at the Johns Hopkins Hospital? Second motion. All in favor? Aye.
Aye.
Also, Commissioner Tamarchio, back. Commissioner Tamarchio, is that you? Are you back?
Yes.
Commissioner? Yes, okay. How about Commissioner Hathey or Commissioner O'Grady?
O'Grady's back.
O'Grady's back. All right. So 3 out of 4 back. Good. All opposed? Hearing none. Congratulations, Edward. Certificate of ongoing performance. Next up is agenda item number 6, presentation, Maryland Primary Care Advisory Council nominations. Melanie Cavalier, Chief of Innovative Care Delivery, and Alana Sutherland, Program Manager in the Center for Health, Information Technology, and Innovative Care Delivery, will provide an overview of the Maryland Primary Care Advisory Council and member nominations. The Secretary of the Maryland Department of Health requested that an advisory council be established to serve in a consultative and advisory role to the Secretary and the MDPCP Program Office. Ladies.
Good afternoon, Mr. Chairman and Commissioners. We appreciate the opportunity to present on the Advisory Council today. So I'm going to begin with an overview of the Maryland Primary Care Program. It is a voluntary program that's open to all qualifying Maryland primary care providers. It provides funding and support for the delivery of advanced primary care, supports the overall health transformation process, and allows for the primary care providers to focus on increased prevention, preventing unnecessary hospitalizations, and managing chronic disease. It is deemed an advanced alternative payment model by CMS under MACRA, and that means it's a care delivery and payment model that incentivizes high quality care. At this time, I'm going to turn it over to Alana to go over the nominations and the council.
All right, thank you. So as the chairman mentioned, the Secretary of the Department of Health requested that a group of stakeholders be convened to provide input on the operations of the MDPCP. The council will serve the Secretary as well as the Program Management Office, which is responsible for implementing the program. In terms of MHCC's role, it will be administrative and to provide support. So starting with the identification of nominees, we have identified nominees in consultation with the Program Management Office and the HSCRC. And these individuals were identified based on their professional roles, their experience with the MDPCP, as well as the organizations represented. And so with the approval of the commission, we will make recommendations to the secretary and move forward with confirming the membership of the council. And then once convened, MHCC will staff the advisory council meetings. This will include drafting meeting agendas and summaries. We'll also be responsible for researching issues that are being considered by the council and for maintaining files of documents and records that are generated by the council. And in terms of the responsibilities of the advisory council, they will serve as a source of expertise and advice on all matters concerning the MDPCP. They'll be responsible for gathering data related to patient satisfaction, opportunities for expansion, as well as program successes and areas for improvement. And this will be done or could be done through surveys or focus groups conducted with program participants. The council will also evaluate program performance data and operational data that's held by the Maryland Department of Health. And with approval from the secretary, they may also request that MDH agencies examine some of the specific issues that are affecting the MDPCP. And finally, they will make recommendations for the annual MDPCP report to CMS. And so the next two slides, we've listed the nominees here for your review. And with that, I will hand it back over to Melanie for next steps.
Thank you, Alana. So with your approval of these nominations, we will be notifying the members. We will then be organizing a kickoff meeting that's anticipated over the next couple months, and then there will be ongoing quarterly meetings after that kickoff meeting. So at this time, we're happy to answer any questions that commissioners may have.
Hi, so I just have a question about the categories Medicare beneficiary and the nominees for, why, nothing against the nominees, but why their particular qualifications. What do you mean by Medicare beneficiary?
And do you want me to take it? Okay. So the two nominees that we have listed, one is James Campbell, who is a representative of AARP. he is a beneficiary as well as a representative that's on other councils that we have. Robin Elliott represents several organizations such as nurses that also represent the Medicare beneficiaries. So she herself is not a beneficiary, but she's representing the consumer voice of those beneficiaries on this council.
Commissioner O'Grady, did you have a question? If you do, you're on mute.
Hi, sorry, a little slow coming off mute. No, I don't. I went back over the materials and I'm quite satisfied at this point. Thank you very much.
Great. Commissioner Hammerslaw.
My question is, given this is a primary care advisory council, and a large portion of primary care in the state is provided by physician assistants and nurse practitioners, I see a lot of physician groups represented on the council, but I don't see CA or NP groups represented. And again, given they're providing a large amount of primary care, especially in some of our rural and underserved areas, I'm wondering when those groups are included in the nomination.
So we don't have one at this time that's included in this nominations list. There were deliberations over a couple of representatives that would be from that group. Again, there were a couple different groups involved in the selection process. So certainly there was no exclusion of those two groups, but at this time we don't have a nominee from.
So we probably should have brought out the charter for the group, which is also something that we went through repeatedly with the Department of Health and the Program Management Office. And I wouldn't say that nurses or PAs were specifically ignored, but we did pick slots. There are only 4 positions that were designated in the program. We did also talk to the secretary about the secretary would designate the chairs, and this sorting process sort of ended up as it is. I wouldn't say for the future we wouldn't consider expanding the group, but at this stage we just wanted to get it off the ground, given the vision is that this group would provide input into modern additional revisions in the program going forward. Melanie mentioned Robin Elliott, who is not a nurse, who she was chosen principally because typically represents consumer interest in the state legislature. Her clients typically include consumer groups, but she also has a number of nurse organization representatives, including the Maryland Nurses Association and the Maryland Association of Nurse Midwives. So trying to balance off that, we thought Robin would be an advocate for when nurses can be brought in as appropriate in these deliberations. But I don't think we're saying nurses shouldn't be involved, but we had agreed with the secretary that we would have 20 people on the group, and that's right now the way we broke it out. But I think there will be other opportunities through work groups and subgroups to get them involved.
May I ask a question?
They may not have been excluded intentionally, but they were excluded.
I understand.
Excuse me? This is O'Grady.
Go ahead, Commissioner O'Grady.
Thank you. I just would like to put a little caution out there. I would be very careful about having people represent more than one interest on a group like this. If someone is the consumer representative, they should that should be their entire portfolio, even if they have expertise somewhere else or a business contact somewhere else. I think on the notion of expansion, if you'd like to have a dedicated seat for nursing, that certainly should be in the plans. But I would feel uncomfortable with the idea that we have people representing multiple different cases. I just think it opens to a conflict of interest.
Commissioner Sargent.
I just wanted to second, I think the idea of having especially on an advisory council where perspectives are important, having a PCP who is a nurse would provide a perspective different from PCP who's a doctor, and could be important.
I just want to agree with that. I think that's a serious omission.
So what we'll do is discuss with the health secretary adding an additional member for represent nurses. I think that's probably the best approach. I would add that I think we should defer approving Mr. Campbell at this time. We've been attempting to reach out to him for several days, and perhaps with the end of the legislative session, AARP was heavily engaged this year in a number of bills, including the Prescription Drug Board. He may have just taken a brief hiatus, but what I would say is my recommendation to the commission is we approve the list of members listed, with the proviso that we will come back to you with at least a nurse practitioner member next month, and confirmation of Mr. Campbell or another representative of Medicare beneficiaries in May, so we could get this going and not delay it. But we're committed to adding an additional representative for nurse practitioners or nurses.
Yeah, correct me if I'm wrong here, but I would say that the use of the terms nurse practitioner and nurse interchangeably is inaccurate in this situation. That we ought to be looking for a nurse practitioner representative here. If we need nursing representatives as well to address things like case management or other areas that are typically handled by nurses, that's a separate question, and it may require both. But I would suggest that we add a nurse practitioner to this group.
We'll do the best we can.
Yeah. Thank you. Other comments? So somebody want to make a motion to approve this with the exception of Mr. Campbell's approval, which will be next month, and with the understanding that we will come back next month with a nurse practitioner nominee.
So moved.
Second.
We have a motion and a second. All in favor?
Aye.
Aye.
Any opposed?
Aye.
Take it that aye, Commissioner Tamarkia, was an approval, not an opposition. All right.
Okay, thank you.
Thank you. Agenda item number 8. The payment for professional services in Maryland. The MHCC is required to report annually on expenditures for privately insured professional services using the Maryland Medical Care Database. The payment for professional services in Maryland examines variation in payment rates for professional services in Maryland and provides a comparison of private in-network payment rates to Medicare and Medicaid payment rates in Maryland for the same set of services. Ken Yates Trotman, Acting Director for the Center for Analysis and Information Systems, will present the results from this study.
Thank you very much, Chairman. Okay. So starting with the background of this presentation, the Maryland Healthcare Commission is required to report annually on expenditures on privately insured services using the MCDD. This presentation today satisfies one of that requirement. A study of privately insured spending will be released later this spring. The sole purpose of this presentation today is to examine the variation of payment rates for professional services in Maryland between large and other payers and compare these rates to Medicare and Medicaid. The data source for this project is a subset of the MCDB, which only relates to professional services, and these are provided by healthcare practitioners, including physicians, healthcare professionals such as podiatrists, nurse practitioners, and psychologists. This data, as mentioned earlier, is only considered in the in-network services. On for the methodology, we assigned Medicare RVUs to the MCDB professional claims by CPT codes. The relative value units reflect the resources associated with each service or CPT code. This allows one to compare resources across services or CPT codes or procedure codes. After then, we assign payments to the MCDB services using the private payer, Medicare, and Medicaid fee service levels. For the private payer, we develop a fee schedule using the allowed amount. For the Medicare and Medicaid, we obtain these fee schedules from CMS and the Maryland Medicaid. So after then, we construct a payment per RVU by summing up all of the payments separately for the private payer, Medicare, and Medicaid, and then divide these separate cohorts by the total RVUs. The payment per RVU allows MSCC to adequately to allow MSCC to evaluate the adequacy of the private payer payments between large and other payers, and also to compare these payments to Medicare and Medicaid. So looking at the impact of payer market share on the payment rates, I must pause here to describe what the market share means. This is not like the individual or small group market, but there's simply two cohorts where we divide the payers into large payers and other payers. So the large payers include CareFirst and United Healthcare, and everybody else gets lumped into the other payers. So we can see here that that looking at all payers combined, we see that the increase from 2016 to 2017, we see pretty much a uniform increase, where we see a 2.7% increase from 2015 to 2016, and about the same, which is about 2.6% increase from 2016 to 2017. However, when we compare the large payers to the other payers, we see that the large payers rates are less than the other payers. And the reason for this is that the large payers make up about 80% of the total number of services or total number of resources or spending for this data. Also, because of that, because of this market dominance, these payers have the opportunity to negotiate the best prices with providers compared to the other payers. So
you're almost finished. Let's add the crows.
So that's the reason why we have a lower payment rates for large payers compared to other payers. Moving on to the Maryland region, we want to see how the payment rates are impacted by regions. Most of the variation is based on differences in resource costs and the mix of large payers and other payers in each one of these regions. We see here that the DC region has the highest rate among these regions, and that is primarily due to the high cost of living in this area. This region is composed of the Montgomery County and Prince George's County, which the cost of living for Montgomery County is about 42 or 43% above the national average, and for PT County it's about 17% above the national average. The District of Columbia, although that is not directly included in this in this region. However, it surely influences this region. The cost of living for DC is about 63% above the national average. Looking at the payments to see how these payments compare to Medicare. I must start off by saying that according to the Congressional Budget Office, which did an analysis on private payers against Medicare, according to the office, private payment rates for the last 10 years was between 10 and 33% of the Medicare rates. However, in Maryland, we have a different story. We see that historically, the private rates have been very close to Medicare, going back to even going back to 2003, where we look at this report with HMO versus non-HMO plans. We see that the HMO plan rates were about 3% less than Medicare, and the non-HMO was about 2% more. The following year was about the same result, about 3% less for HMO and about 2.5% more for the non-HMO. Looking at 2010 through 2012, we see that the private rates were about 9% of Medicare in 2010, about even for 2011, and about 2% lower in 2012. So here we are coming to 2016. When we look at the all payers combined, we see that the rates, the private rates are about 3% lower than Medicaid in 2015, about at Medicaid in 2016, about 3% more in 2017. When we look at the other payers, we see the other payers are consistently above the Medicare rates, and that's primarily because, as I said earlier, we have the larger payers who make up about 80% of the data. They have the strong negotiating power to negotiate with providers to really get a more competitive rate. So if they are having a lower rate, the other payers pretty much shadow price what these large payers have. So therefore, the other payers' rates are higher than Medicare. Lastly, looking at how the payment rates are compared with Medicaid. We have seen that for all of these payers, the private rates is consistently above the Medicaid rates, which one would expect. For the other payers, we see it is substantially more than the large payers, ranging from 18% more in 2015 to about 20% in 2016 and 2017. I must note here that for Medicare payment rates, although Medicaid payment rates are higher than the national average, about 35% higher, the Medicaid to Medicare rates are about 88% of the Medicare rates. That's all I have. Questions?
Yes.
So can you kind of give us a general summary, Medicare rates versus Medicaid rates against the private payers? I mean, so where are we? Are the payment rates for private payers below the Medicare rates now? Is that what you're saying?
The private payer for Medicare rates as of 2017 is about 3% above Medicare.
Above the Medicare rates?
Yeah.
Okay. And then Medicaid, obviously.
Medicaid, the private is always higher.
Sorry.
So, yeah, this isn't shown in the chart, but just because we characterize it as close to Medicare doesn't mean that when we looked across E&M services, surgeries, i.e. procedures, diagnostics, that we've seen that same relationship. In general, E&M services are at Medicare rates or sometimes a bit lower. procedures are oftentimes a bit higher, as are imaging and lab services. So characterizing this and trying to translate this to an individual practitioner is a bit different, because depending on the services you provide, if you're a surgeon, you would be shocked to say what Medicare and private payer rates are the same. Generally, for surgeries, you would find that Medicare rates are maybe 20% lower or more than what's paid in the private sector. If you're a primary care physician, you might say they're about the same, or maybe even a bit lower. The other thing that I think Ken emphasized was that these results are consistent with what others have found, the Healthcare Commission historically, as well as the Congressional Budget Office, who has pegged professional fees in the Mid-Atlantic and East and New England as typically lower than professional fees in the Midwest and West, in part because of historic fee levels, in part because physician consolidation is much greater in those parts of the country. I just point to Michigan or to Wisconsin, where basically three healthcare systems control the entire physician population, and they're able to negotiate very favorable rates in that state, because they're able to go head to head against payers and negotiate with equal leverage.
So I think that's an important comment here, because when I look at this as a physician, I think the story is missing. And the story is that we are not, and the last data I saw shows it's the bottom decile nationally in physician reimbursement.
Right. It probably hasn't changed much.
Right. And that's not here. All you're doing is comparing it to Medicare and Medicaid, which is, when we look at it from a hospital perspective, those things match, because we have an all-payer system that's intended to keep rates equivalent between the two. And we've regressed to that on the physician side, but the rates on the Medicare and in the Medicare system, nowhere else in the country are adequate to cover the costs of running a practice. Yet when physician practices in Maryland go to recruit new physicians, that's the talent pool that we're competing with the rest of the country for the talent pool. And it becomes very, very difficult. I think what this artificially does is it shifts the cost to health systems who need it to fill their panels with a broad spectrum of physicians, and recognize they can't do it, they can't pay for it based on these types of reimbursement rates. It shifts the cost to the hospital side, and the HSCRC sees these huge hospital employment costs for physicians, and this is why, because we can't compete in recruitment when rates look like this. And I would argue that we've got an anti-competitive practice that leads to that. And showing that with the large payers paying even less, and in fact at times below Medicare rates.
Right.
Nowhere else in the country does that occur.
And I agree on that. We looked at this total cost of care model that we're talking about, that we're under now, and we're focusing, obviously, there's a lot of dollars on the hospital end. The physicians, really had to suck it up over the years to take much less, and so it's time that we start looking at ways to help on the physician side, because the recruitment's a problem. The hospitals, no question about it, are subsidizing doctors.
Yeah, exactly.
Which adds back to the cost of the hospital. So
I think that's exactly right. It's not that physicians are sucking it up anymore. They can't.
Right.
You can't be employed. You can't be self-employed in this model with these types of rates. They're employed either by a large health system or by or by a school of medicine in other examples. Right.
So in other words, this story is somewhat misleading.
I think so.
It is very hard to, from the standpoint of the state, to benchmark where Maryland stands. We've had to do that basically through a synthetic analysis, comparing some other studies and trying to shoehorn those methodologies in with our approach, and then guessing it. The national studies on this have sort of tailed off as other issues in healthcare have already gone to the fore, but I hear what you're saying.
All righty. Thank you, Ken.
So, want to go back.
Lawanda, yeah, I apologize. Yeah, I skipped over a section. The 2019 legislative session ended on April 8th. Small clap. This session, the commission was focused on legislation that implemented recommendations of the CON modernization report that MHCC submitted to the General Assembly in December. Prominent legislators in the Senate and the House sponsored 3 bills that were consistent with report recommendations. All of these bills passed. LaWanda Edwards, Program Director for Government and Public Affairs, will provide us with a summary of the legislative session, and then she'll describe studies and reports the Commission will need to complete prior to the start of the 2020 legislative session. LaWanda.
Yes. Hi. Good afternoon, everyone. My name is LaWanda Edwards, and I'm a part of the Government Relations team. And as the chairman just mentioned, the legislative session wrapped up earlier this month, April 8th. This is the legislative wrap-up and the results of the 90-day legislative session. And also, as the chairman mentioned at the beginning, the last few days of the session were overshadowed by the untimely passing of House Speaker Michael Bush, who had been a really good friend to the commission. Sorry about that.
That's right. But why don't you?
Okay. All right. I apologize. This presentation will discuss the budget bills, legislation that passed and failed, as well as new opportunities that await the commission. The budget bills, as we all know, that the budget was enacted, both the budget and what we refer to as the BRFA, or the Budget Reconciliation Financing Act of 2019. More than $34 million of special fund appropriation for MHCC, reflecting an $8.1 million reduction in the ICNs, impacts HSCRC, Maryland PCP, plus $100,000 of additional appropriation for operating funds to the Shock Trauma Center at the University of Maryland. $500,000 of MDH's appropriation is contingent on completion of assessment of services provided at the University of Maryland Shore Medical Center in Chestertown. And there was no change to the trauma fund. MIMS will submit 2 reports this year. The first report with HSCRC on ER overcrowding solutions will be done by November 1st of this year, and the second report on progress of EMS new model reimbursement on December 1st of this year. And that report will be assisted by the commission as well as HSCRC. HSCRC must identify total cost of care goals and quality measures for Medicaid and report this by December 1st of this year. The next is an update on our CON bills, and our executive director, Ben, went into a little bit of that earlier. We had a pretty good, successful, a very good, successful session as it relates to our CON bills. As many of you all know, we had submitted a report in December that gave recommendations on the modernization of CONs. The first bill, House Bill 626, this bill was an emergency bill and was enacted, has been enacted and went into effect immediately. One more immediate impact will be on the CON application for Carroll Hospice. The second bill, second group of bills, HB 646 and Senate Bill 597. They both passed and were very successful. We worked with the chair of HGO on getting those bills passed. Last, HB 931 and Senate Bill 940. Both passed retail satisfaction.
And surge bill, damn surge bill.
And then such bills, yeah. HB, excuse me, next. HB 607 and Senate Bill 901. As you had mentioned a little bit about this earlier, Ben, the commission, of course, supported both bills which passed and are awaiting the governor's signature. The bills provide park and shock trauma. They provide park and shock trauma with access to the on-call and standby cost payments from the trauma fund. And of course, this is significant to the commission since we manage the trauma fund. The next one, House Bill 924 and Senate Bill 733. The commission did not take a position on this legislation, but both bills passed the chambers. This bill is significant to the commission because we must conduct a review of hospital cardiac care catheterization laboratories in the state that includes specified information and submit its findings to the governor and the General Assembly by October 1st, 2023. And the next, I'm not going to go into detail on this sheet at all, other than just to mention that there were a fair number of bills that we followed for various reasons that failed. And to be honest, most of them just didn't come out of committee, so they weren't voted on. The next, the commission has a number of new responsibilities resulting from the 2019 legislative session. It's important for all of us to note that these responsibilities are in addition to MHCC's ongoing obligations, including a number of studies from last year's session that will conclude this summer and fall. Again, we talked about this a little bit earlier. The Trauma Fund, MHCC will develop a methodology for funding standby costs at Park as required by House Bill 607 and Senate Bill 901. And more examinations will be done on the reimbursement policies under our authority in the existing statute. For the psych services, if an updated state health plan chapter on psychiatric hospital services is not adopted by December of this year, the commission must submit a report directed by House Bill 626. And as mentioned earlier, there will be a task force beginning to meet in May. The Maryland PCP funding plan, the remaining funds for the Maryland Health Insurance Program, are part of which had been reserved for Maryland PCP, were transferred in the BRFA. HSCRC and the Commission will submit a joint report by September 1st of this year. And Ben, you had mentioned, we talked about this earlier about Chestertown and the assessment. We'll have to go any further than that. For the mandate studies, several bills related to insurance mandates failed. The Commission is waiting to see if the committee's request follow-up for the mandate studies. This is a continuation from last year, the new EMS models payment methodology costs, as we talked about. And MIMS and the Commission will develop a plan for reimbursement for 3 EMS new models of care and submit a report by December 1st of this year. And this, of course, is directed under House Bill 100. The Commission will conduct an actual impact analysis on mandating carriers to reimburse for these services. Letters from the chairs of HDO and the Senate Finance are forthcoming, and the chairs may request additional mandate studies. Other longer responsibilities, the new Prescription Drug Affordability Board, in consult with a stakeholder council, HSCRC, the Commission must monitor and assess the impact of policy actions taken by the board and report findings and recommendations by January 1st of 2023. The last one, the Cardiac Catheterization Lab and Cardiovascular Invasive Specialist report. House Bill 924 and 733, as we mentioned earlier, directs the Commission to collect information from the Department of Environment, the State Board of Physicians, and MHA on hospital cardiac catheterization laboratories in the state and report that information by October 1st, 2023. And lastly, Megan Vann and I will be working with Center directors to discuss possible legislative priorities for next year. We're going to look at further CON reforms, and Ben, you may want to say more about that? No? Okay. And we talked about this earlier. We will receive recommendations from these various work groups that are listed here, and that will have other ongoing studies as well. And that concludes my report. Are there any questions?
Thank you very much. Any questions for LaWanda?
Thank you.
I'm just curious what the role of MHCC will be in the prescription drug affordability. A little more clarity on that.
I can certainly get you more information on that, Commissioner Boyle. Right now, we're working with MHA to figure some of those things out. Okay, I'll get back to you. Thank you. Any more questions?
So just to, I mean, we do have the prescription drug claim data that the major sort of linkage back to MHCC was the prescription drug data that we collect from private payers, Medicare through a data use agreement, and Medicaid. I suspect this piece of legislation will undergo a court challenge, but you know, our role would be to be a data supplier at this point.
Very good. Thank you. Agenda item number 9, presentation, Experience of Care in Nursing Homes Report, results from the 2018 Family Satisfaction Survey. The Commission administers an annual nursing home family experience of care survey. The 2018 survey process is complete, and Stacy Howes, Chief for the Long-Term Care and Health Plans Quality Initiative, will summarize the survey results. Stacy.
Good afternoon, Commissioners. Yes, I have the results of the 2018 Nursing Home Family Experience of Care Survey. So this was designed to elicit levels of satisfaction with loved ones' care in a Maryland nursing home. And we survey responsible parties, and responsible parties are often loved ones or a family member, but sometimes they're a friend or a neighbor, sometimes they're even a power of attorney. And we use the results to evaluate quality of care and performance of Maryland nursing homes. And the scores are used in Maryland Medicaid as part of the Pay for Performance program, and it's 40% of the score. So it was first pilot tested in 2005, and then we began administering it almost yearly in 2007 through 2016. And now we're back on track for yearly as of 2018. We made several changes to the 2018 survey. First of all, we added a Spanish language version. Unfortunately, there were no takers on that this year, but we hope to market that a little bit better this year to see if anybody else will take us up on it. We also added 13 questions because during the 2016 administration, the contractor did an analysis and determined that there were multiple gaps in the information that we were gathering. So we drew from other states and from the nursing home caps and added 13 questions. So now there's 37 core questions, and 31 of those are used to calculate 7 different domains. And then we have 2 overall items that measure overall satisfaction and the percent who would recommend that nursing home. And then there's 4 screening questions. Those don't go into any calculations. And then, of course, we have 11 demographic and background questions. So we contacted nursing homes back in July and asked them for a list of all long-stay residents. They provided us with a list that included a loved one and a contact information. So once we received the nursing homes list, we examined them and cleaned them, and we deleted anybody that was short stay, and we also had to exclude anyone where the resident and the responsible party were the same person. If the responsible party was not listed, or if the address for the responsible party was incomplete, in a nursing home, or was outside of the United States. All nursing homes participated as expected, and our response rate from participants was 49%, so it was quite good. From the data, we were able to calculate 7 domains. The 4 that are not in bold carry over from previous administrations of the survey. They each have additional questions as of this year, but they carry over from previous administrations. And the 3 domains that are in bold are brand new to 2018. And then, as I mentioned before, we have 2 overall measures, the overall rating of care received and the percentage who definitely would or probably would recommend that nursing home. And then, of course, we divided the nursing homes into 4 different peer groups that included the region of the state, the size, the ownership type, and the payment source. So these are the overall results for the state of Maryland. The first 7 lines are the domains that I just mentioned, and they are on a scale of 1 to 4. And then the second to last, the overall rating, that is a scale of 1 to 10. So if you examine these, you can see that these are all in the good range, reflecting a good level of satisfaction with Maryland nursing home care. Now, these are the 4 domains that I mentioned carried over from previous years. Thank you. That carry over from previous years. And the dark green bar represents 2018 scores. And in each case, you can see that the score is a good score, but it is statistically significantly lower than each of the prior 4 years in all 4 categories. And then for the overall rating of care, we see the exact same pattern. 2018 is a good score, but it is statistically significantly lower than each of the 4 previous years. And then the percent who would recommend the nursing home is the same pattern. 2018 is a good score, but it is statistically significantly lower than each of the 4 prior years. Because we were concerned about the decrease, we wanted to ensure that the decrease wasn't a result of a statistical or technical artifact of some sort, so we conducted a few additional analyses. The first thing that we did was we reconducted the analyses based on the 2016 criteria, but the results remained the same. It was still a statistically significant drop compared to all 4 previous years. We were also, due to logistical reasons, we had to administer the survey a little bit closer to the holidays than we would have liked. So we wanted to make sure that it wasn't an effect of the holidays. We found that 75% of the people who responded well before Thanksgiving, and there wasn't any substantive differences between people who completed before and after Thanksgiving. And then we looked at each individual item to see what changes might be, and the patterns were consistent with a slight decrease. So the responses shifted for virtually every item from in ways such as always to usually or usually to sometimes. There were not dramatic shifts. So the pattern was persistent. The pattern was present with virtually every item, and it was consistent with a small but significant decline. As I mentioned, we had the nursing homes divided into peer groups, and we compared the state scores to each of the peer groups, and what we found is that for all 7 domains, the overall rating and the percent who would recommend the nursing home, the state score was significantly lower than Western Maryland homes, small homes, and not-for-profit homes. And the state score was significantly higher than for-profit homes. These results were expected and are consistent with prior years. So again, because we were concerned about the drop in the ratings, I reached out to the nursing home community and asked them to share their thoughts on what they thought might be a cause for the decline. And I heard from 18 people, and they all said virtually the same thing in different ways. And it fell into 2 different categories: patients and family issues and staffing issues. So when it comes to patients and families, almost everyone told me that they feel like patients and families are much more educated than they used to be. They are using the 5-star ratings, and they are reading information that's available out there. Some family members can even recite regulations by heart. They also mentioned that newer federal regulations that were enacted a few years ago, specifically phases 1 and 2, have gone into effect. And they feel like as a result, there's harder surveys and patients and families they notice because, again, they're more educated. This next one might be a little bit longer in coming than just the last 2 years, but everybody mentioned that expectations have changed. So basically, baby boomers are much more demanding than previous generations, but then also the children are more demanding. Several people mentioned that they feel that patients are younger with more mental health issues, and sometimes that extends to family members, and then nursing homes aren't always equipped to handle this issue. And also multiple people felt that there was less of a chance to bond with patients and families than in the past. And of course, staffing. Long-term care is not seen as quite as appealing as hospitals and doctors' offices. For example, in hospitals and doctors' offices, they feel that they can get better pay, a more exciting level of care, or even weekends off. And several people mentioned to me that GNAs were quite difficult to find, retain, and train. And of course, Medicare and Medicaid cuts often lead to staffing cuts, or at the very least, not refilling the position that becomes open. And then this one you've also probably heard, they feel like they're spending a significant time addressing regulations rather than patient needs. And this last one, only one person said to me, but I thought it was worth mentioning. They mentioned that their nursing home has a resident satisfaction survey that they administer, and there was a drop in that satisfaction as well. So I feel like that we need some more awareness about our survey on our website to help continue with education. And we are engaging in several plans to enhance awareness and through simple campaigns that people from my center have discussed with you before. And I think it's very important to note that even though there was a decline in satisfaction, the results are still in the good range in all categories statewide, but I think we need to pay very close attention to any changes in 2019.
Thank you. Comments, questions? Commissioner Matt.
This is my area. I was one of the people that called in.
18.
Yeah. So, I mean, our facility does very well. I think we got like a 9.3 out of 10, and we were higher than all these with 100% satisfaction. And ours actually, it was very good. It's always been very good. But, you know, these areas, I can't argue with a lot of the things here. I mean, there's, yeah, I advise facilities, we're for profit. I mean, but it ranks as high on the pay performance scale as #1 in the state. So there's a level of diligence there. We're a smaller facility, but I mean, I agree with this. The level of expectations has changed. I think one of the things that have changed that maybe not so much education within some of it's education within the you know, the 5-star system, et cetera, and just the population in general. But part of it is, you know, you can't turn on the TV where you don't see somebody went to a nursing home. And it's just inundated. And, you know, and it used to be, well, it still is, you know, one of the nightly news shows will run a very big profile on abuse in nursing homes. And sometimes it's not even a nursing home. Sometimes it's abuse in the assisted living facility, but they still call them nursing homes. So an assisted living facility burns down, and the headline reads, the nursing home burns down. You know, that plays a little bit. GNAs are excruciatingly difficult to hire. There's an overall shortage in the state. There's no question. I mean, we sponsor people. I mean, we've done our own program, all kinds of different ways to try to mitigate that. But it's difficult. It's really our only area of turnover. All my other departments, even my professional nurses, very little turnover. But that's a thing. That's your frontline staff. It's an ongoing challenge all the time. I wouldn't say in the glamour thing there between hospitals, et cetera. It is. And I have we have hired a nurse manager to our facility after 28 years at the hospital. She's excellent. I mean, she's superb, and she was just blown away at the level of difference in regulation and requirements in long-term care versus the hospital. I mean, she's still coming up to speed on. She just couldn't believe it. One of our most recent audits within the system, the auditor laughed at her and said, you know, baptized by fire. because she said, you're a newbie in long-term care. And it scared me a little bit, 'cause she said, you know, anything more regulated in long-term care is nuclear power. And I think it's probably true. You know, I've been doing this I grew up in the industry, and I've been administrator for 25 years and an owner for 20 years. And I can't say with any level of confidence that increased regulations that have changed over the years and improved quality one bit. I can say that with pretty good confidence. I've seen it change, et cetera, phase 1, phase 2, et cetera. When you come into our facility now, you know, I got nurses in offices that have to do compliance work that would have previously those funds been used on the floor toward direct care, et cetera. I still got to do that, but it eats up your available funds to do things. You know, and it's very popular. It's very politically very popular to Senator Grassley in the United States Senate. Very popular for him to hammer on nursing. It gets a lot of traction out of that. But Medicare, Medicaid cuts, you know, we really didn't get cut, but the way we're reimbursed changed. And how you acquire your funding changed. It's very difficult. And, you know, at our facility last year, I saw a significant reduction in revenue. Was able to still see our scores go up for quality care, but we had to modify some of the ways we were doing things to gather that revenue. And with the change in Medicare, has another change coming here in October, huge change. So everybody's gearing up for that, and that'll be a big challenge. So I was really impressed that the commission, you know, sought to reach out after the fact and say, why do you think? I'm kind of disappointed that only 17 facilities called in. I mean, I thought that should have been closer to 150, but you know, maybe that's why they don't have quite a good rating. I don't know, but so that's my 2 cents on all this. You know, great quality care and achieving good ratings is not impossible. Western Maryland, you know, we live up there, I guess, by ourselves at times, but you know, maybe we take care of our people with smaller populations, smaller communities, less likely to give people bad ratings, et cetera. So,
a question to the surveys, man. The things that we're hearing about, the reasons that the survey's gone down, are things that are applicable across the country to every nursing home and across the state to every nursing home. And when you have your own survey that you use to survey your own state, you don't get the opportunity to compare to the rest of the country. So is there a reason that we don't use the CAHPS version for this, or is there not a CAHPS version for nursing homes?
There is a CAHPS nursing home version. We don't use it, but we use several questions from it. We actually ask more questions than the nursing home CAHPS.
So we can't compare it to nursing home CAHPS?
It could be compared, yes.
That would be very valuable for
Okay.
us, right, to be able to understand what these numbers mean. Because, you know, a significant difference from 90 to 80, if we're still in the 90th percentile nationally, that's one thing. If that didn't change anything because everybody went down nationally because of something else that changed, the items that Commissioner Metz listed, many of which apply, that's one thing. And if we're in the lowest decile nationally with those scores, we need to know that too.
Yeah.
And we don't. I can't get anything out of that from what we're seeing.
I can work on it.
Thank you. Commissioner Peters.
I also wanted to say that part of this seems like a lot of the issues could be related back to staffing. So the reason you can't hire DNAs is because they have too many patients per DNA. And so then they quit and you can't retain them. So, and then the patients that are more likely to have like a connection to them. Also staffing, if you have 12 patients that you have to go and get up and get out of bed and feed them and feed and change, there's no time that can be spent. So I think a lot of that goes back into how many residents or patients are you expecting one nurse or DNA to really deal with? Yeah, that's a good point.
I mean, that's very true. So, like, you know, like the state minimum is 1 to 20 staffing ratio, which is, I mean, that's outrageous. Okay, it's crazy outrageous. And occasionally facilities get cited on it, you know, but you know, in our facility on my daylight shift, I'm typically a 1 to 6 ratio. So that impacts. I know that's great for our quality. And second shift, not quite as much, but still great. Because there's just not as much going on, not the bathing, et cetera, and you get down, of course, when they're sleeping a little bit. But, you know, I have 66 patients and 31 for 36 another, and, You know, like I said, I'll have a 1-to-6 ratio on daylight, and I'll staff in on the second shift, mainly go up to 1-to-10, and then the last shift gets down a little bit more, but never below like a 1-to-15 ratio. Never down there where probably more like 1-to-12. So it does. I mean, that directly affects that. But we still see very challenging, and there's between facilities and for-profit facilities, and one of the challenges we're running into is, and this is kind of crazy, and I try to explain this to our staff, because right to what you're talking about, Dr. Peters, is one facility will advertise and pay a little bit more money to a GNA, maybe even $1 more an hour, and then they go into the facility and they're dealing with a 1-to-15 staffing ratio instead of a 1-to-6. And then about a month later, they're calling me up and they're saying, "Hey, I want to come back." So there's that game goes on too, because some of the reimbursement models have changed where folks can pocket that money and different things that went on where in the past they couldn't necessarily do that. So there's a whole lot of variables. My area, I could talk about it all day. I don't say a whole lot here because you guys are gurus in the other areas, but when we get to this, it's what I do.
Thank you very much. Ben, would you like to share the upcoming activities for the May public meeting?
So I don't have a complete list yet, but I know we are really focused on a couple of CONs that focus on site beds. We hope to bring those to the commission. I know David's team has a plan for one of his health IT reports. We have a report that we're hoping to present to you. Ken alluded to it earlier on spending it for the privately insured. Those are definitely will be on the schedule, and we expect to have a couple more items, but being mindful that the presentations need to be efficient, and we'll look at getting you the essential information, but trying to complete the meetings in 3 hours. I did want to note that that LaWanda and Stacy, this was both of them presented for the first time. We sort of argue about who gets to go last because we know everyone's really tired, and I appreciate their organizing their presentations well, being succinct. But I also want to thank you for your attention late in the day. So you all, regardless of the holiday you're celebrating this weekend, have a nice time, and we'll see you in a month. We will be sending out a notice to you on the farewell dinner for Commissioner Moffitt. I know Bridget's working on it, and we've asked him to provide a couple days that would work for him, and then we'll work with the chair to get everyone on board to the extent we can. The plan is for it to be in someplace in the Annapolis area near his home.
Thank you, Ben. And I want to add my thanks to staff for outstanding and largely succinct reports. Thank you. At this point, I would entertain a motion to adjourn. Commissioner Hammerstein, is there a second? Commissioner Peters. Any opposed? Thank you, everyone.
Thank you.